Hello, this is Dr. Vijay Batuman. It's my pleasure to welcome you to today's presentation. Our speaker today will be presented by Dr. Marcia Glass. She will also be the moderator of this presentation. Dr. Glass, take it away, please.
Thank you, Dr. Batuman. Dr. Lowenburg, welcome to Grand Rounds. He's an assistant professor at Tulane University in clinical psychiatry. He went to Middlebury College and then Tulane for medical school, residency, and fellowship before joining faculty. Dr. Lowenburg's interests include forensic psychiatry, serious mental illness, substance abuse treatment, and medical education. His clinical work includes working at the State Forensic Psychiatry Hospital. He's also an ACT team psychiatrist and the medical director of Bridge House Grace House, an 150 nonprofit residential substance rehab that treats patients regardless of ability to pay. Dr. Lowenburg is also the immediate past president of the Louisiana Psychiatric Medical Association, LPMA. Ben has 2 young kids, and he says so far they have not required too much therapy as adults to process his parenting.
Thank you. Thanks, Dr. Glass. And we were talking earlier how being from Tulane kind of helps because you and I met when I was first in med student on rounds. So thank you so much. So I'm going to go ahead and try to share my screen. Let's see here. So we're going to share the screen and we're going to... Uh-oh. Let's stop. I'm going to try it one more time, guys. I apologize. Okay, can y'all see my presentation? Okay.
Yes, we can.
Great, thank you. So I'm going to present on medications for addiction treatment. I'm going to be talking about meds, but also addiction in general, because this is such a prominent topic and an important one. So I have no financial disclosures, but I do have a plug for 2 programs. One is the Addiction Medicine Fellowship at Tulane, which is a new fellowship a few years ago, and it has about 4 fellowship positions per year, and it is grant funded. So anybody can apply who comes from any primary board or even some specialty boards as well. It's led by Dr. Roy and Dr. Singletary, who are not actually on this conference because they're leading a different conference, which is the Project ECHO. And so this is for anybody, Project ECHO, who may have an interest in treating addiction or may even do it already. And it's the goal of Project ECHO is that we provide support to people in primary care and throughout the state who may not have that support they need in treating addiction. So please feel free to reach out to us at any point. So what I'm going to do today is I'm going to talk about medications for the treatment of addiction, but I think before we do that, we need to review what we're going to define as addiction, as well as, of course, the opiate epidemic. We're going to talk about some biological effects of addiction, and then we'll talk about medication-assisted treatment. And I'm going to call it medication-assisted treatment, or MAT, because that's a term that we have used for a long time, and it's actually a term that is even in some laws now. And so it's kind of one that will be there for a while, but I will mention in a little bit. I don't necessarily love that terminology the best, and I'll talk to you about that a little bit. And then we'll talk about medications specifically, and then what is the evidence on it. So when I became medical director at Bridge House approximately 2 years ago, we weren't really doing a lot of MAT, and part of that has, I'll talk about, but part of that has to do with stigma, but also a lot of barriers. And so this is one thing that we've really been trying to bring in more and more, just at Bridge House and Grace House, but also you're seeing a lot of initiatives, grants going on. So for one thing, I do want to review addiction. Oh no, let's not go forward. There we go. And we'll talk about the diagnosis of addiction. So, of course, I can't go anywhere without referring to the DSM, which is the main manual we use when we talk about addiction or when we talk about diagnostic disorders. And so we kind of break addiction down into substance use disorders, and that's the terminology we use. And we talk about different criteria of substance use disorders. And those criteria or symptoms can be broken down into 4 general categories. So excessive amounts or time used in substance, the development of tolerance or withdrawal, hazardous use despite multiple negative outcomes, as you can see, as well as cravings and unsuccessful attempts to cut down. So this is the DSM-5, but also we have other diagnoses in other organizations, and I like one definition from the American Society of Addiction Medicine, and it talks about addiction as a chronic relapsing disorder. So I'll just read it. Addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. And if we think about it, there's many illnesses, and as people in internal medicine, you could list them going from diabetes to rheumatoid arthritis to depression to cystic fibrosis. There's many diseases that have chronic relapsing and remitting courses, and addiction is no different. So we can see, I'm not going to go too far into this slide, but we can see chronic relapsing and remitting courses involves symptoms that include behavioral manifestations. So for a lot of illnesses, the symptoms are visible to the eye, and for us, the symptoms may not be as visible to the eye, but we also have to look at behavioral manifestations of illness as well. But we need to look at the biological effects. So first, I would like to review the opiate epidemic a little bit. And these stats are from 2017. But if you look at it, if you look at all-cause mortality in 2017, breast cancer was at 40,000 people. Auto accidents were 40,000 people died from auto accidents, 44 from suicide. 72,000 people died of overdoses in 2017. So this is a very significant amount. In 2018, I believe it went up a tiny bit and then might have plateaued last year. I don't recall exactly, but the far majority of overdoses were opiates. One thing I do want to point out is this is overdoses, but if you look at alcohol-related deaths in 2017, it was actually in the low 80,000s. So I am going to talk about opiates primarily, or to a large extent, but I'm not trying to ignore the fact that alcohol use disorders has a lot of deaths from related complications going forward as well. So in 1999, you could see the opiate epidemic was largely concentrated in southwestern, western, and even the Appalachian area, southwestern, western, and even the Appalachian area. And even in, and then in 2014, you can see it's just everywhere. And so, of course, you're still seeing Southwestern, you're seeing Appalachian, but you're seeing coastal, you're seeing Northwest. It's dramatically increased. One thing I do want to point out is that while overdose deaths since 2002 had progressively risen significantly, while overdoses have progressively risen. Let me try that one more time. While substance use has progressively risen, overdose deaths have gone up even more so, exponentially. And one of the main reasons that we see for this is the synthetic opioids. So as synthetic opioids have been becoming more and more prominent, of course, we hear about fentanyl, we hear about even the extra fentanyl, carfentanil, but we can also talk about prescription medications as well. So as we see more and more synthetic opioids, the deaths are going up even in an even higher proportion than we see continued use. So biological effects of addiction, and I'm just going to cover this a little bit. We see different substances can affect certain areas of the brain, obviously. So we talk about alcohol and benzodiazepines affecting GABA receptors. We talk about opiates, of course, affecting the opiate receptor. But all of them do play a large role on the dopamine receptor. And that's really our reward feedback. So cocaine, methamphetamines, those of course even more so affect the dopamine receptor. But what often happens is when the reuptake of dopamine is blocked by cocaine, more dopamine is in the synapse, and people are going to be feeling that real addictive and rewarding effect from substances. One thing I would point out is dopamine is a good thing, right? It makes us feel good. It helps reinforce good behaviors, and it keeps us alive both as an individual and as a species. So when you eat food, we release dopamine. When you eat chocolate, when you have sex, dopamine is released, and all of those things are reinforcing good behaviors for our person and for our species, if you will. But what happens is when cocaine or other substances, and cocaine is what's used in this example, but any substances come in there, that completely overruns the reward mechanisms. And so when, say, food releases 2x amount of dopamine, drugs can release anywhere between 2 and 10 times that amount. And so when we see this large amount of dopamine release, people are going to be short-circuiting their rewards pathways. I am putting this in there so you can see this is a basic representation of the rewards pathway in substances. So it includes the frontal cortex, our VTA, and our nucleus accumbens. For brevity's sake, I'm going to go ahead and skip that, other than to point out that there's very clear receptors that different substances are affecting, and that is also being mediated or reinforced with dopamine. So this is the classic development of tolerance thing that you may have seen over years. This one's from 1966, but it still holds today. And that is when somebody first uses a substance, in this case it's heroin, the high is felt relatively quickly and easily. And that's that first time that somebody uses and that they're going to be, quote, chasing that high. So they feel that effect relatively quickly. And over time, as they use, they'll see it going up and down. But as we all know, our bodies are very malleable and react to different situations. And so our bodies will downregulate receptors. And so that what normally receptor is out there, it's getting hit by dopamine when you eat a great piece of chocolate, those receptors aren't as prominent. And so now people are not getting the stimulation even for normal activities, but also not when they use the substance, because those receptors are downregulated. And so over time, substance is needed, talk about heroin, for example, both to feel normal, but also to prevent withdrawal. And so what you see down here in the development of tolerance is people are not getting the high over time, or far less so, and it's more needing the substance to just feel normal to account for those receptors. The good news, and so this is just another visual representation of that. This is SPECT, and so people with opiate use disorder, you see far less SPECT and looks at function and blood flow, but you see far less effects and brain lighting up on SPECT than somebody who's been using for a long amount of time. One thing I point out to counselors, but I think it's very important for us all to remember as providers, is when you have somebody who comes into your office who is using substances and has a substance use disorder, an illness, their brains are acting differently and looking differently. And so I talk with counselors about, well, if you're going to have a counseling session, you're assuming that the person in front of you, the person in front of you has a brain that's acting like yours, like this. Well, in fact, maybe they have a brain that's really not acting in the same way as all, and you need to take that into account. We'll talk about symptoms, but symptoms of this can include poor concentration, poor frustration tolerance, as well as significant other cognitive effects as well. The good news is our brains are elastic. So if this is Dr. Volkow, who is a very famous addictionologist, and she actually leads, oh shoot, is it SAMHSA? Some of her original studies and publications said, well, look, we do recover. So it's somebody who is chronic methamphetamine, and methamphetamine significantly affects dopamine. It's kind of like cocaine to the max. So methamphetamine, for somebody who's normal, you're going to see good dopamine stimulation or good dopamine usage. And after 1 month, people are still showing a lot of deficits, but even after 2 years, people do recover. So, so that's very important to remember. So what is medication-assisted treatment? Medication-assisted treatment is the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach. It's really important to remember this is medications for an illness, but so is glucophage for diabetes. And so we don't say medication-assisted treatment for diabetes when somebody's taking metformin. What we say is medications for the illness. And so that's what I consider medication-assisted treatment. So somebody who has diabetes will need to take, will need to make behavioral changes in what they eat and what they drink and what they consume. But they, in many cases, may need to make medication changes. And that's how I think of medications for the treatment of addiction. So we're going to talk about benefits of MAT. So number one is it reduces opioid use. It reduces both the amount used, but also the days and months that somebody may be using, the days per month that somebody may be using, or the number of weeks with drug use over time. The next thing is it protects against opiate-related overdoses, and we'll talk about the different pharmacologies and how some of them specifically protect about that. The other thing is it protects about for injection behaviors. So remember, anytime anybody's injecting, and they're at higher risk of hepatitis C, HIV transmission, but also they're at a higher risk of becoming a victim or participating in criminal activity. Of course, when somebody is pregnant, substance use is very dangerous to a fetus, and so it can, for pregnant patients, MAT is used and is recommended to prevent low birth weights, premature birth, complications, and going forward. It also improves retention in treatment, decreases relapse rates, and then the last thing that I think is super important to remember is it decreases risks of death 15 times over. And this is all causes. So yes, we're talking about opiates, but we're talking about other risky behaviors, other medical illness. And so one thing I do want to point out is there has been over time, and it's less so, but there has been over time a lot of resistance to medications for the treatment of addiction. And I'll talk about that as well. But very few other illnesses do we see a treatment that decreases all cases, all causes of death by 15 times over, and people do not go to it. So I think it's important to remember that this is a life-saving treatment for people with an illness. So I'll talk about some data, of course. Success rates for people who are on MAT versus abstinence versus not on medications for the treatment of addiction. And this is an early in the course of recovery, so in the first 3 months. We find in general that MAT helps people stay in treatment for significantly longer, and it increases chances for future success. So in this study, about 65% of patients were still in treatment at the end of 3 months who were on MAT versus about 20% who were in treatment who were not on medications for the treatment of addiction. Long-term outcomes at both 18 and 30 months, greater than 50% of patients who are on MAT are able to maintain their sobriety. So let's talk about some misconceptions for medications for the treatment of addiction. One thing is that people tend to say, I'm going to trade one addiction for another. So I'm going to stop using heroin, but then I'm going to be addicted to Suboxone. And one thing to remember is MAT is treating a biological illness. And so I will talk about addiction and substance use disorders in a medical model, and there are other models to think of it, but MAT is treating a biological illness. And so research continually shows that the combination of MAT and behavioral therapies is going to get the greatest chance of success. In one case, somebody is using a substance under uncontrolled circumstances, in uncontrolled environments, and in another, they're seeing a provider who's following them closely and also providing therapy and behavioral substance use disorder treatment in addition to medications. People talk about people who use MAT as taking the easy way out. They're saying you're not sober if you're on MAT. And then we're going to talk about diversion. One thing, again, I would recommend is if you think about diabetes, some people may need medications for the treatment of diabetes. Some people may need purely to alter their diet. And then there's a variety of levels of treatment for diabetes depending on the severity. And I think the same thing goes for addiction as well. So the take-home point is medications for the treatment of addiction saves lives, increases the chances a person will remain in treatment, and then also increases the skills that they learn and will build towards for recovery. So let's talk about medications. So I want to talk a little bit about alcohol use disorder first. And alcohol use disorder, we tend to use 3 classes of medications for the treatment of addiction: naltrexone, acamprosate, and disulfiram. I'm not going to talk right now about other medications, excuse me, that we may use for depression or anxiety, because of course you do want to treat and address any other psychiatric illnesses that are going on, but I'm going to focus on these. So the first thing to talk about is naltrexone. So naltrexone blocks opioid receptors. It is a full antagonist, but the way it works is it's going to decrease the rewarding aspects of drinking. And so what we find is people who take naltrexone, they have decreased cravings, but also the decreased need to go to the races, if you will. So say somebody is taking naltrexone for alcohol use disorder, and they have had a really bad month during COVID, and they just had this need to go out and drink, and maybe they open a beer and they have half a beer, and after a little bit they say, you know what, I'm going to put this away. Well, before they were taking naltrexone, maybe that one beer led to the next, to the next, to the next, and this can kind of help limit the rewarding aspect of the alcohol by affecting dopamine and make it easier to stop earlier. The next thing is acamprosate, and that affects both GABA and glutamate receptors. And I'm just going to say right now, we're also going to say it decreases the reward feedback and also decreases cravings. If you think about GABA and glutamate receptors, this is going to be my own personal side. Acamprosate can be used for people who drink to deal with anxiety, but I would say that it's far more complicated than that. So I wouldn't just go straight to acamprosate when you have somebody that comes in that says, I'm anxious and I drink, but it can be used in those cases. The last case is disulfiram, and if y'all remember back from your biochem, it inhibits aldehyde dehydrogenase, and by doing that, you're not actually affecting anything in the brain. So whereas both acamprosate and naltrexone were treating, partly trying to address one of the causes for drinking. In this case, you're not affecting the brain. You are just pretty much putting in a negative consequence. And so when you inhibit aldehyde dehydrogenase, that then causes somebody to get sick and feel really horrible if they've had a drink. So while the first two tend to be used a lot more by addictionologists because we're really trying to treat the illness, but disulfiram does have its antabuse, does have its uses in certain specific cases as well. And of course, it had uses prior to the others coming around. Although naltrexone has been out for 30 plus years, I believe. So, so let's kind of talk a little bit about opiate use disorder. Oh, by the way, I will go back. So for naltrexone, acamprosate, and disulfiram, all of those are PO once daily dosings. Vivitrol is a naltrexone long-acting injectable. It's given once every 4 weeks. It's an intramuscular injection, and it's a slow release. One last thing I keep saying one last thing. One other thing I will mention about naltrexone is because it is an opiate antagonist, people need to know this when they're prescribed it, and you need to be talking about how this can affect them should they get in an accident. And the short answer is, say somebody has a medical emergency that they go to the hospital. If they alert the hospital that they are taking naltrexone, it can be overcome using certain opiate medications, such as, certain opiate medications. It's just important that they make sure that their providers know this. So now let's talk about opiates. So I'm going to say, so if we talk about receptors, we're going to say there's a full agonist, which is methadone, a partial agonist, which is buprenorphine, and an antagonist, which is naltrexone. And I'll go back in a second. And so for those, a full agonist is going to stimulate the receptor in a full way. Buprenorphine, as a partial agonist, will grab onto the receptor. It has a high affinity for a receptor, meaning that it's going to grab that baby really tight and then not let go when that receptor is exposed to other things such as heroin. And then naltrexone also has a high affinity for the receptor. It's going to grab it and again not let anything on it. The difference about a partial agonist is, as buprenorphine, while it grabs that receptor, it has high affinity, it stimulates it to a point. So it levels off over time. And the benefit is that you can get receptor stimulation to help cut down on cravings, to help with withdrawal. But at the same time, you're never going to be able to stimulate the receptor strong enough to really give a significant amount of the high feeling, and it will prevent heroin from doing the same. So again, to go back, methadone is our full agonist, buprenorphine is our partial agonist, and naltrexone is our antagonist. So within buprenorphine, I do want to cover a couple of things. We have buprenorphine with naloxone and buprenorphine without naloxone. Naloxone, the medication we use to treat overdoses, is also, of course, a full antagonist. But here's why this is useful. It's useful not because it actually does anything. It's useful because it does nothing when used appropriately. So naloxone is broken down by first-pass metabolism. And as you can see, buprenorphine for these are sublinguals. So you're putting the strip, and I'll talk about it in a minute, you'll put the strip or pill under your tongue. It's absorbed by the mucosa under your tongue, and that is bypassing first-pass metabolism as well. The naloxone is actually not really absorbed, and anything that is absorbed through the GI tract gets spit out, and you really shouldn't have any effect. But if you try to inject a strip that has naloxone in it, you do bypass first pass metabolism. It is not broken down, and that can lead to withdrawal. So it is used as a method to prevent the diversion of Suboxone, which you see is one of the buprenorphine with naloxone products. The other two you may have heard of are Bunavail and Zubsolv. There is sublingual buprenorphine without naloxone. That includes Subutex and Belbuca. Those we tended to use a bit more to prescribe to women who were pregnant because we were concerned about the naloxone. The more recent studies have shown that we really don't have to be concerned about the naloxone in those cases for women who are pregnant, and Suboxone is very regularly prescribed to women who are pregnant at this point. There's two other newer formulations. One is Sublocade, which is a sub-Q monthly injection, and that it's a sub-Q monthly injection, creates a pouch almost kind of in the abdominal wall, and that is absorbed slowly over the month, so people do not have to worry about taking a medication every day or multiple times a day. Probufene actually is a 3-month implantable tiny little implant, and then we mentioned naltrexone as well. So we talked about that, and this is just another quick kind of look at the different approved FDA administrations of MAT. So I did talk about this already to an extent, but buprenorphine with naloxone, Suboxone, I talked about the partial opioid agonist as well as the plateau effect. It has a very long half-life. Because of that, it can typically be dosed once daily, but we do, of course, have BID or even TID doses up to 24 milligrams. So if you look right here at this, it almost looks kind of like a little Listerine strip that somebody takes and puts under their tongue. It's an 8 milligram strip, and sometimes we can even have patients cut the strip to give us smaller doses if we're titrating. It has a less euphoric effect than other opioids. I mentioned it being paired with naloxone to prevent diversion. And then the last thing is to prescribe Suboxone or medications for the treatment of addiction. We'll talk about buprenorphine. To prescribe buprenorphine, you do have to have a DEA waiver, an X license. The good news is it's actually quite easy to get. You do have to do an 8-hour course. There's multiple organizations that provide them, including the Louisiana chapter of ASAM, American Society of Addiction Medicine, the Louisiana chapter of the American Psychiatric Association, and they're really easy to do. And then you fill out a form online and you become able to do it. One thing I will say is there used to be a lot of concern about prescribing it. You know, is the DEA going to bother me? Are people going to divert? And what we found over time is there is such a need for buprenorphine that they're trying to make it as easy for qualified providers to prescribe it as possible. So I did kind of briefly talk about pros and cons. Low overdose risk because you can't overdose. Again, you maintain retention and treatment. You can prescribe in the office, which is easy to do. No cardiac toxicity, no neonatal abstinence compared to methadone. And again, remember, we do prescribe this in pregnancy. Cons are the training, the 8-hour training. Cost to some people, although it is covered by Medicaid. And so we have a lot of patients at Bridge House and Grace House that we refer to a Suboxone provider or addiction medicine provider that they can continue to follow with. It can complicate pain treatment. I may go into that a little bit today, but treatment of pain in the midst of substance use disorders is a whole nother topic that's excellent to cover. It can be done well and effectively, but I'm going to leave that for another day. And there can be diversion. The next thing is methadone maintenance, that full agonist. one of the reasons it makes such a big difference is it has a very long half-life, right? So medications or drugs that have very short half-lives, you have the up and down. And so with the longer half-life, you're going to decrease the need to continually try to up that dose. So there's once daily dispensing, and it's at federally qualified methadone clinics. So there's one just downtown, BHG, Behavioral Health Group, I believe, and they're a methadone clinic. And you have to have you're followed very closely by the FDA. So pros for methadone, there is very significant increased retention in treatment. There's decreased opioid use, all the things that we talk about for MAT. Just need to be aware that it does have some interactions with other medications, and there is a significant burden when it comes to getting the medications, because a lot of people have to go, or most people will have to go to that methadone clinic in the morning to get their methadone. One thing to say is that increases accountability. So there is a behavioral component to having to go to the methadone clinic in increasing accountability, increasing engagement that comes with it. The last thing is naltrexone, and this is the opioid antagonist I did talk about. And both with the oral daily dose and the extended release dose, it does block opioid receptors, as we were talking about. And what I would say is, I think it can play a significant and important role. The pros are, it is not controlled. So any mid-level provider can prescribe it, and often does. It can last for up to 28 days, and that's the Vivitrol formulation. And it can treat both opiate and alcohol use disorders. The other thing it can be used for is treating other addictive disorders. And I'm not just talking about substances. So we can use it, and it can be used off-label for other substance use disorders to try to decrease the reward feedback. But it can be used for gambling disorder or sex addiction. And so sometimes, or even in some cases for compulsive disorders such as eating disorders in some cases. Cons are you do have to be aware of liver function. That being said, you can prescribe it to people who have liver compromise. You just have to be aware. And then remember, it's not the is not the risk of it versus not the risk of it. It's the risk of naltrexone versus the risk of continuing to use and the effects of continuing to use illicit substances on your liver. The last thing is you've got to be opioid free. So if you give somebody an opiate antagonist and they have not started to withdraw, then you are going to throw, if you give somebody an opiate antagonist regardless, you're going to throw them into withdrawal. And so you need to have them opioid free, have gotten them through withdrawal before you can start prescribing naltrexone. So what I would say is each modality is important. And so there are patients that I prescribe naltrexone for. There are patients that we prescribe Suboxone for or Buprenorphine for, and there are patients that we prescribe Methadone for. I don't prescribe for Methadone. I would refer to that Methadone clinic, but I would continue to treat them and do continue to treat other illnesses. So one thing to know is MAT is not necessarily a short-term treatment. So the studies have shown that the longer that you receive MAT, with generally a minimum of about 1 to 2 years, the better the chance of continued sobriety in the future. So let's talk about evidence. And I'm going to start with a Lancet article from 2003. And if you look, it's actually it's not relatively, it's a small N, but this is such a prominent graphic that I've seen in many places. And I think it's important to kind of touch base on is in a 365 day or so in 1 year, they looked at people who were prescribed buprenorphine, Suboxone, while they were in treatment. And in both of these groups, they were receiving individual counseling 3 times a week, but one was receiving buprenorphine maintenance, the red dots, and one had received a buprenorphine detox and then did not receive medications for the treatment of addiction. So at 1 year, 15% out of 20, so 75% of people who were prescribed medications for the treatment of addiction were still abstinent, were still maintaining their sobriety, whereas by 2 months, all of the patients who were not receiving medications for the treatment of addiction had relapsed. Even more importantly, there were 0 deaths in the group receiving medications, and there were 4 deaths in the group that had not received medication or buprenorphine for the treatment of addiction. So that's an old study. But what I will say is we've gotten a lot more studies, a lot more data that has shown consistently that this is a pretty busy slide, but I've shown consistently that the duration of treatment is important. So pretty much all of these come up to say that the longer a taper is, the better. The chance of poor outcomes goes up significantly when following a taper, and then the last thing is the further out that somebody is from having been prescribed Suboxone or buprenorphine, the more likely they are to have positive drug screens. Pretty consistently, if you look at treatment abstinence while you're getting the medication, we see a variety of successes, but all of them go down significantly after people have completed a buprenorphine taper. So the conclusion for most of these studies is that the prescription of medications for people with opioid dependence, even after 12 weeks of treatment, increases outcomes. So without it, the risk of unsuccessful outcomes is very high. So again, this is just to kind of reinforce what we were talking about in the beginning, but at 3 months, maintenance people are staying in treatment at much higher rates than people who are not getting it. So, and then this is true not just for buprenorphine. So this is true for methadone as well. So the estimated days of opioid use per month. So if people do have relapses, the number of days per month continues to be significantly higher in people who do not have medications for the treatment of addiction. So I do want to talk about diversion, and it's important because that's something that we talk about a lot, and that's one of the biggest discussion points against medications for the treatment of addiction. And one of the things we find is most people who use buprenorphine not prescribed by a doctor are not using it to get high. They're using it to self-medicate their either withdrawal or their dysphoria, what they were using their opiate for. So it's rather than people trying to use it to get high, it's more they're trying to provide themselves medical care, obviously not in an ideal way, and that's often how diversion happens. So when I have somebody come in and they say, "Oh, I took that on the street, I don't need it," one of the questions I ask is, "Well, why did you take it?" And almost always it's not to feel high, it's more to feel normal or to prevent my withdrawal. But one thing I do say is, but that's not treatment. So you may have used it in that case on the streets, but that's not treatment, because now you've got a medical professional, you have behavioral techniques, and we can look at how we can help treat your addiction. Patients do need to be given advice about medications, i.e. What to expect, what's detox going to look like, what are symptoms that you need to look for, but also what is the duration treatment, knowing that this is something you will need for a period of time, and you need to have plans for follow-up. So the length of treatment, again, I mentioned is generally 1 to 2 years plus. So there have been people who've been treated for 6, 7, 8 years or more, and that medication they're doing very well on, and that's their need. There's other people who say after 6 months, I really want to try to taper it off. And so what I tend to say is the longer the better, but I try to discourage tapering off at less than 6 months. And there's really no evidence to support stopping MAT at this point in time. Obviously, once people have really achieved their levels, have achieved their sobriety, have been maintaining it for a while, if they want to slowly work themselves off in a way that you can do it and accommodate for those receptor changes, that's certainly reasonable to do. But I would argue you shouldn't feel obligated to try to do it as quickly as possible. And then the last thing I do want to kind of briefly touch on is where do professional organizations stand? And so it's pretty clear that almost everybody looks at the evidence and says, okay, this is important. So SAMHSA, NIDA, ASAM, APA, WHO, U.S. Surgeon General, National Council of Behavioral Health, everybody says we support MAT, we support it, we recognize the benefits. And one thing I do want to point out is what about Alcoholics Anonymous, AA? And 12-step programs. And the reason I do that is because we do get some resistance and some pushback from some people who are in AA I say subscribed solely to the AA model. And so what I say to them is, I believe in 12-step programs. I believe that they work. And we also know that addiction is a biological illness. So when AA started in 1935, we knew nothing or very little about addiction. And AA served a very important role and continues to do so. But AA has also adapted over time to new medical evidence. And so new medical evidence clearly supports and shows that there's a genetic and biological basis to addiction and that it's important to treat it with medications. And AA agrees with that. And so sometimes when you have an old AA group member who says, man, I'm not gonna do anything, I don't wanna allow anybody in our group who takes anything to treat their addiction, what I say is I recommend you go back to your AA literature and look at this. Because there's a few points in AA literature that specifically talk about medications for the treatment of addiction. They say no AA member should play doctor. Medical advice should come from a physician. But also, if you look at prior writings, they say that, well, sorry, apologize. That if you look at prior writings, AA has advocated in the past against the putting pills in your system, but really those were talking about other things, and AA has come back to change that. And so you can look at writings from Dr. Chang, who was very prominent in AA in the 90s, and she talks about using therapy, counseling, but also Valium, antabuse, naltrexone, acamprosate. Dr. Ruth Fox was the founder of ASAM, and she regularly prescribed antabuse to family, friends, patients, and colleagues. And so AA very clearly does say that the treatment of addiction with medications is appropriate when it is done in conjunction with your doctor. So I'm going to end on the story about the man in the flood. And this is not my story. It is one that is used in AA meetings, but I think it actually holds very well when it comes to medications for the treatment of addiction. So a man is in a town that got flooded. We'll say it's New Orleans. And he was sitting on the top of his house, and a neighbor rode by and offered him a ride. Man declined, saying, "Thank you, but God's going to provide for me." An hour later, the police come by in a boat, and they say, "Hey, why don't you hop on in?" And the man says, "No, thanks, I'm good. You know, I believe in God. He's going to take care of me." the police roll on. So, and each time the water grows higher and higher, and he moves up to the tip of his tip of the house as the water's getting higher, and a helicopter comes by and offers him, says, "Hey, hop on, let's get you out of the flood." And he says, "No, I believe in God. God's going to take care of me." And the water comes, floods, the man dies, and he goes to heaven, and God says, "Hey," and man's upset, and God says, "I sent you 2 boats and a helicopter. What else do you want?" And so AA members really like this, but I think it's important to know that our patients are fighting a FUD. This is something that affects them biologically, but in many, many ways when it comes to their relationships, when it comes to their mental health, and we need to give them every mode possible to try to treat their addiction. So, I want to thank the following references. I've got some others, but also last plug for our 2 programs, the Addiction Medicine Fellowship and Project Echo. So I think that is it for now. Thank you all very much.
Thank you so much, Dr. Lowenburg. We learned a lot over here at UMC. And I just wanted to remind everybody who's listening in, please feel free to type your questions in the chat box, and I will just read them out so Dr. Lowenburg sees them.
It's not the chat box, it's the Q&A box. There are 2 questions, Dr. Glass.
Oh, yes, right. Sorry. This is from Doug Rovira. He had earlier said, and perhaps behavioral addiction such as gambling. Dr. Schamberger is asking, is the X waiver necessary? Seems like a barrier to distribution.
Yeah, so for Dr. Yeah, so why don't I talk about the X waiver real quick? So the X waiver is a DEA waiver. It is a barrier to distribution. And the reason it's complicated, that comes to a legal thing. So it is a DEA waiver. Not just everybody can prescribe it. You do have to have it, but anybody can get it. So any provider can get it after they do this 8-hour course. And so I'd say is right now that's kind of what we have. There have been talks in the addiction community about trying to open it up. It's not at that point yet, and we'll see if it goes there. But that's kind of what the government does right now, and that's the way it's maintained. It has to do with using medications to treat addiction, and just how complicated that has been over the past couple of decades. When it comes to medications for nicotine, sorry, I did see that that Doug had asked.
Yes, there was also a question about a brief comment about medication treatment of a nicotine addiction.
Yeah, so medications for the treatment of nicotine addiction, it's kind of similar actually, interestingly. So we have agonists, right? So we have nicotine agonist replacement therapy. So we talk about gum, patches, lozenges. So that's nicotine agonists that you can taper somebody down with. Oh gosh, why am I blanking? Chantix is actually a partial agonist, much like buprenorphine is. And it works in a similar way. So you would start Chantix before somebody stops. You're getting some of that receptor stimulation from your Chantix, the varicycline. And so that will partially stimulate, and then it is a long-acting partial agonist that will slowly go down on those receptors over time. But that's how that works. And then the last thing is we do use Wellbutrin, bupropion, it has been shown to be effective as well for the treatment of nicotines.
In the interest of time, we only have about 5 minutes, so I'll just hit some highlights here. A patient who is currently incarcerated, trying to discharge with Suboxone. Do you have any recs?
I would say have that person reach out to me. That's a tough situation. So it's a very tough situation. There is strong, prominent advocacy trying to get medications for the treatment of addiction into prison populations, into people who are incarcerated. It's important, it's valuable, it's not there yet. Interesting, I think defund the police movement, which some people may argue about branding, but one large component of that is how do we treat addiction? How do we treat mental illness? How do we help treat other social factors that are contributing to that? That's a long story, but if that person wants to email me, I can try to help direct them.
I think also it would be good a separate conversation with you and Dr. Fonseca, because he's asking about metformin in veterans with PTSD and diabetes, and talking about randomized trials with addiction.
Yes, I think that, yes, give me Dr. Fonseca. Yes, reach out to me.
Dr. Schamberger is saying, do you think it's appropriate to start patients on MAT in the hospital? Do you have good retention rates after discharge?
Follow-up is key. So it is appropriate to start MAT. In fact, at university, they do have a program to try to identify people in primary care and in the ER to really kind of get them into MAT. And so it may be appropriate to start that in the ER, but follow-up is key. And so what I would say is prescribing a medication without follow-up is not appropriate, but it needs to be done with a program. And so ideally, in a perfect world, yes, we would be doing that. People who are coming in, whether they've overdosed or in the midst of withdrawal, we would be starting them on medication with appropriate close follow-up.
And then for Dr. Brady, can you comment on the use of gabapentin for alcohol addiction?
Oh, goodness. So that's a complicated one. It has been shown to be effective, and it has been used. And we do use it. In fact, it's probably one of the most prescribed medications we see at Bridge House and Grace House. I wish I could go on more about that. There is some yes, but or yes, ands to that. And that component is when you are in settings for people who have used substances to alter their cognition for long periods of time, whether that's in rehab or whether that's in incarcerated settings, any medication that even somewhat alters consciousness may be rewarding. And so we do sometimes see gabapentin used, for example, in incarcerated settings inappropriately. That all being said, I would go back to the important part of the far majority of people who use it in an appropriate way, and it can be very helpful for treating alcohol addiction. Particularly, I've seen it used most, and I've used it most with people who also have anxiety going on, and it can help some with cravings, but it also, I've even seen it used for detoxing people, or at least in studies, to detox people from alcohol as well. So
thanks, Ben. In our last minute, Dr. Byrne asking about restating the point, I think asking for clarification around the point of substituting MAT for another addiction.
Yeah. So I would. So I think it's a very important point, and I thank her for bringing that back up, is MAT is not substituting addiction. It is not taking the easy way out. Is recognizing that people have a biological illness. It's looking at the studies, looking at our biochem, and recognizing that we need to treat biological illness with biological agents. And so because somebody has tried to treat their own, and this often comes up, you say, oh, well, they used it on the street. Because somebody has tried to treat their own illness, probably very ineffectively so, does not mean that so the diversion component should not limit your thought process of saying, this person has a biological illness, they're doing everything they can, and we need to treat their illness, it's not replacing it. Same way that, yeah, I'll stop there.
Thank you guys so much for a tremendous discussion, and for Dr. Bodeman for hosting. Bye, everyone.
Thank you.